Good morning to all of you. This is Dr. Shwetabh. I will be presenting my topic of challenges in oral feeding in craniofacial anomalies and special needs feeding. The specific learning objectives of today's talk will be: we will dealing with the introduction, challenges, cleft lip palate, craniofacial abnormalities and syndromes, and special conditions along with the feeding difficulties with them. So beginning with the introduction, cleft lip and palate are among the most common congenital anomalies. And if we see at the incidence of cleft lip with or without cleft palate is 1 in 600 to 700 live births, while that of the incidence of cleft palate is 1 in 1000 to 1500 live births. So before discussing about the difficulties in the feeding, we have to understand about the mechanism of feeding. So various organs of our mouth help together for the feeding, which includes tongue, jaw, lips, cheeks, and palates. In the tongue forms a seal around oral cavity, anterior with lips and posterior with soft palate, and hence it creates a positive pressure by compressing nipple against the hard palate. And it also creates negative pressure in the sealed oral cavity by lowering slightly, thus enlarging the space. It also stabilizes the nipple and helps formation of channel by forming the central group. Similarly, jaw creates a stable base for movement of tongue. Lips create an anterior seal of oral cavity with tongue and nipple. Cheeks provide stability as intraoral pressure changes. Now, the problem with the cleft lip is there is inadequate closure around the nipples. Hence, there is problem producing a powerful suck to extract milk. Though the problem is less in unilateral clefts, but it is more evident in the case of the bilateral cleft lips. And if associated with cleft palate, then the problems becomes even more. In the cleft palate, basically the problem is the inability to form a complete seal and negative pressure efficient enough to expel milk and trigger successful swallow. And hence, without negative air pressure, swallow cannot be properly triggered and aspiration or choking may occur. So if we see an assessment of sucking and feeding in various deformities, then the cleft lip, if the patient is having cleft lip only, then the problem is more with generation of negative pressure. However, the ability to make mechanical movements is there. But if the patient is having cleft palate, then also there is a problem with generation of negative pressure. And if the patient is having both the problems, then the problem will be with generation of negative pressure, along with which ability to make mechanical movements. So it is difficult for breastfeeding in the case of the cleft palate more than that of the cleft lip. So the aim of the feeding will be the feeding method should be selected on the basis of feeding efficiency and safety, and it should be completed within 20 to 30 minutes, because longer feeding may lead to net calorie loss due to excessive energy output. So how to breastfeed in cleft lip parents? Babies, to start the flow of milk, feeders should massage out a little milk before feeding begins, and the cleft lip can be sealed either by filling the breast in the defect, or the mother may be able to put her thumb on the cleft to create a seal, or the lips can be generally hold to create a negative suction. Basically, the most important part is to create a good positioning so that the seal is formed properly. The recommendations in the case of the unilateral cleft lippage, the mother can adopt a position of modified football method in which baby lies in the side way, and then mother is able to breastfeed the baby, or the chin can be supported during the breastfeeding, and hence the mother may use her free hand to support infant chin and breast to maintain a semi-upright position so that the jaw is stabilized and baby can feed efficiently. In the case of the bilateral cleft, the dancer position is advised, in which hold the hand is used to hold the breast, and then baby can feed effectively. However, in the cleft palate, it is advised that the angling of the nipple should be made toward the area of the intact palate, and then the infant may be able to milk the areola and nipple with tongue pressing it against the roof of mouth. Defect and lip palate can be also used to fill the breast tissue. As we can see this in this image, infant with cleft lip and palate are can be after opening wide to latch for a feeding, and then the infant can feed properly. Then there are assisted milk delivery systems in which bottle nippers are used, which are the popular options are Mead Johnson cleft palate nurser, Haberman feeder, pigeon bottle, or Palladi feeding. The concept behind is that there are different techniques which work for different infants. The most appropriate feeding technique would be any type of device that delivers adequate milk into mouth and allows the infant time to swallow. When bottle feeding, a soft bottle is preferred. The position of the feeding should be that the baby should be hold at an angle of 45 degree, and this is an incorrect position of feeding in which the baby is in the lying position. In the essentials of bottle feeding, we have to squeeze the bottle intermittently, and the squeezing should be rhythmic, and we have to not continuously squeeze the bottle, because it will make the flow of milk fast, and it will be difficult for baby to control. There are different types of feeders which are available. We will be discussing three important feeders. First is the Haberman feeders, in which there are, as we can see, there are two bottles. First is this big bottle, then there is a teat, then this is in mouth. If we clear the
Hold the bottle upright, squeeze the nipple between your fingers, and then tilt the bottle upside down.
Then the bottle is filled like this.
There are shortest line, meaning regular or high flow, under the
then
infant's
it
nose.
is squeezed in a rhythmic
The
fashion so
barrel-like
that baby can feed
reservoir
properly.
attached to the nipple may also be squeezed to increase the flow of milk. The best guide is a ring.
Next is the Mead Johnson feeder, which is basically a simple bottle, but the walls are more flexible so that it can be squeezed properly.
Delivery bottle. It's a softening manner.
So
if
in
you
a soft
squeeze
manner,
too
we can
hard
squeeze the bottle,
or with a
and the baby
constant
will get the milk.
pressure, your baby may take in too much milk.
Third is the pigeon bottle, which is available quite easily, and in this there is a long teeth so that we can insert it inside the mouth, and baby can take the feed
The
properly.
silicone long nipple has slits, and a part of the tip is cut off. Milk in the bottle and tilt it. The milk will spill. The milk will not spill. This is how milk is pumped from a silicone long nipple. Pinch the nipple with tip.
Now there are prosthesis or palatal abbreviator, which are devices designed to provide a normal contour to the patient of cleft alveolus and hard palate, which separate oral and nasal cavity so as to provide a surface to oppose a needle, a nipple. The advantage it helps in feeding and facilitate lip and palate repair. So like this is a device which is obturator which has been placed so that as to differentiate between nasal and the oral cavity. Then the spoon and cup feeding are advised before operation so that the baby can be completely weaned from bottle, because after palate repair the bottle of the bottle nipple can rub against the stitches and break down the repair. A long handled spoon with a flat ball can also be used. The irritating food like citrus food and tomatoes are not recommended as they have acidic quality. Then oral care after feeding. Once the infant finishes feeding, the area should be cleaned, and if the feed is left to accumulate, it can mix with the mucus secretion from the mouth and form a hard crust that becomes a potential source of infection. To clean this area, clean water or water with hydrogen peroxide can be used. In patients with cleft lip or palate, it is difficult to properly clean the maxillary incisor due to clefting. Then transition into adult feeding starts at approximately 6 months, and is done in other children. Thickened feed has to be used because they generally don't get lodged in the cleft, and spicy food has to be avoided due to sensitivity of nasal mucosa. Now, craniofacial syndrome, the most important is Purey-Robin sequence or micronathia, in which there is small recessed jaw, mandibular hypoplasia, tongue is high, and hence tongue is not in appropriate downward and forward position to attach the nipple, and there is limited mouth opening. So the issues is that very difficult to place the nipple correctly on the tongue, and the nipple is positioned in the front of the tongue, and thus the baby may not be able to use the tongue to compress the nipple, and liquid may squirt out from the front of the mouth, which is successive suck, and respiratory issues are also there. So in the feeding strategy, prone or side lying position can be used. NG2 feeding have to be tried. Long nipple have to be used, and low flow nipple are more useful. And bottle has to be periodically removed after every 1 to 2 sucks. The important syndromes are like craniofacial macrosomia, DiGeorge, and Treacher-Collins syndrome, in which in the craniofacial macrosomia, NG feeding is advised along with oral sensoromotor stimulation. In the DiGeorge syndrome, specialized bottle can be used, and GR has to be managed along with management of precophageal dysfunction. While in Treacher-Collins, small and slow feed are advised. Now, special need feedings. The first and foremost is the babies of neurological conditions like that of the birth, perinatal asphyxia, etc. Basically, if we see that the proper pathway, then it involves suck, swallow, esophageal action, and coordination of breathing. A baby with neurological issues can have discoordination at any point of this step. So the feeding strategy will be to encouraging first of all non-nutritive sucking, adding cheeks and or chin support during feed. Cup or spoon feed may be trying. And as previously discussed, dancer hold is advised. For the hypotonic babies, the pleat seat or sling baby carrier can be used, in which the mimics the fetal position and relaxes an infant who is hypotonic or arcing away from the breast. In the GER patients, feeding in a sitting position or partially laid back position may cause fewer symptoms, and there we should give frequent breaks to bubs, particularly if there are frequent loose suctions at the breast and thus take more air. And parents are advised to keep the infants upright for 30 minutes after feed and sleeping in semi-upright position. Now, mainly in chylothorax, we have to use TPN, followed by which enteral feeding are started as soon as possible using breast milk with medium chain triglycerides. So take-home message will be feeding the baby with cleft lip palate or micrognathia presents a challenge for the parents and health professional. Assessment of effects of the oral facial anomalies are important first step to identify effective feeding strategy. While oral feeding is reliable, one can often be achieved effectively. Infants with more severe feeding problems may require some amount of tube feeding. However, by working together, solutions to the most difficult feeding problems can be found with support of parents and healthcare professionals. Thank you.